Madam President, I come to the floor to note a sad anniversary. Friday, March 1st, marked the 6th year since the tragic death of the 12-year-old Maryland child named DeMonte Driver. I have spoken about him many times since his passing, which happened just weeks after I came to the United States Senate. The death of any child is tragic. DeMonte was even more so because it was entirely preventable. He died from an untreated tooth decay. It started with an infected tooth. DeMonte began to complain about headaches in early January 2007. By the time he was evacuated at Children's Hospital's emergency room, the infection had spread to his brain, and after multiple surgeries and lengthy hospital stay, he passed away. The principal at DeMonte's school, Gina James, remarked, "Everyone here was shocked. They couldn't understand how he could have a toothache and then die. We sometimes give the little kids a candy as a reward. Well, for a while, they stopped taking it because they would say, 'If I get a cavity, will I die?'" Because DeMonte did not get a tooth extraction that would have cost $80, he was subjected to extensive brain surgery that eventually cost more than $250,000. This is more than 3,000 times the cost of an extraction. After DeMonte's death, more Americans began to recognize the link between dental care and overall health that medical researchers have known for years. Former Surgeon General C. Everett Koop once said that there is no health without oral health. The story of the Driver family has brought Dr. Koop's lesson home in a painful way. Medical researchers have discovered the important linkage between plaque and heart disease, that chewing stimulates brain cell growth, and that gum disease can signal diabetes, liver ailments, or hormone imbalances. They've also discovered that oral disease is far more prevalent than you might imagine. In fact, dental decay is the most common chronic childhood disease in the United States. Dental disease affects 1 in 5 children ages 2 to 4, and more than half of all children have dental disease by the time they reach the 2nd grade. By the age of 17, approximately 80% of young people have had a dental cavity. Children living in poverty are twice as likely to suffer tooth decay as middle and upper income children, and nearly 40% of black children have untreated tooth decay in their permanent teeth. This has serious implications in their overall health, and these problems carry over to adulthood. Improper oral hygiene can increase an adult's risks of having low birth weight babies, developing heart disease, or suffering from a stroke. These are sobering statistics, but here's the good news. Dental decay is a dynamic disease process and not a static problem. Before a cavity is formed in a tooth, it carries infection can actually be reversed. That means that we can prevent tooth decay as long as the dental care is made available and good oral hygiene practices are used. DeMonte's story was told around the world, but nowhere did it hit harder than in my home state of Maryland. I am proud of how the Maryland congressional delegation, Governor Martin O'Malley, and the Maryland General Assembly have responded to the needs for better access to oral health. In 2010 and 2011, the Pew Center of the states named Maryland a national leader in improving dental access for low-income Marylanders. We were the only state to meet 7 of Pew's 8 dental policy benchmarks, and we ranked first in the nation for oral health. CMS has also invited our state officials to share their story at its National Quality Conference in August 2011 and placed Maryland's achievement in the Best Practices Guide. I will mention just some of what Maryland has accomplished. In 2010, our state secured $1.2 million in federal funds to develop a statewide oral health literacy campaign called Healthy Teeth, Healthy Kids. More than 368,000 children and adults in Medicaid received dental care in 2011, 82,000 more than 2010. Created by the Robert T. Freeman Dental Society and funded in part by the state, the DeMonte Driver Mobile Dental Van Project provided diagnostic and preventive services for over 1,000 Prince George County children who live in neighborhoods where otherwise care would have been unavailable to them. The Kaiser Family Foundation awarded a $200,000 grant to the Maryland Dental Action Coalition that funded a pilot dental screening program at a school-based health center in Prince George's County. I am also very proud of what Congress has done. In the CHIP Reauthorization Act passed a few months after DeMonte's death, we established a guaranteed oral benefit for children With the leadership of Senators Balkis, Grassley, Rockefeller, and Collins, and former Senator Bingaman, we created grants to states to improve oral health education and treatment programs. We also addressed one of the problems that DeMonte's mother faced in trying to get care for him, a lack of readily available information about accessible providers. For a variety of reasons, it's difficult for Medicaid and CHIP enrollees to find dental care, and working parents whose children qualify for those programs are likely to be employed at jobs where they can't spend 2 hours a day on the phone to find a provider. So HHS must include in its Insure Kids Now website a list of participating dentists and benefit information for all 50 states and the District of Columbia. Then in 2010, we passed the Affordable Care Act, which was a landmark provisions to improve oral health. The ACA funds and encourages a number of oral preventive activities. First, it directs CDC to establish a 5-year national oral health education campaign. This campaign is required to use science-based strategy and to target children, pregnant women, parents, the elderly, individuals with disability, and ethnic and racial minority populations, including Native Americans. The Affordable Care Act also creates demonstration grants to study the effectiveness of research-based oral health programs, which will be used to inform the public education. The health care law expands an existing school-based dental salient program to each of the 50 states and the territories, and to Indian tribes, tribal organizations, and urban Indian organizations. The Affordable Care Act also authorizes HHS to make grants to dental schools, hospitals, and nonprofits to participate in dental programs, training programs. The law authorizes and requires a number of public health initiatives that should improve access to oral health care, including $11 billion 5-year initiative that funds construction, capital improvements, and service expansions at the community health centers where so many oral health services are provided. But perhaps the most important provision is the requirement that health plans cover a set of essential health benefits that includes pediatric dental care. Beginning in January 1st, 2014, the law says that oral health care for children must be part of the essential health benefit package that is offered under the new health insurance exchanges and in the small group and individual insurance markets that exist outside the exchanges. Madam President, when the ACA was passed nearly 3 years ago, I had great hope that in a few years I could stand here on the Senate floor and celebrate all the progress we have made in bringing affordable dental care to every child in this nation. I'd hoped that this would be a day to talk about what a difference Congress has made in oral health of American children. We celebrated that section of the law because it meant that once and for all, oral health would be available to all American children. It gave me and many of us hope that we'd be able to get every child basic dental care and begin to erase the dental disease that still affects millions of American children. Now, however, the affordability of that benefit is at risk. The ACA includes a Finance Committee provision that allows a standalone dental plan to exist in the market. In a colloquy on September 26, 2011, Senators Balkis, Stabenow, and Bingaman engaged in a colloquy that clarified the intent of the law in allowing a standalone dental plan was not to create separate standards, but to ensure competition in the insurance exchanges and to allow choice in the marketplace. Later, I joined 10 of my colleagues in writing to HHS Secretary Sebelius, urging her to ensure that all children who receive their dental coverage through a standalone dental plan should have the same level of consumer protection and cost sharing as those who get coverage through a plan that offers an integrated benefit. In other words, one set of deductions. That's what we intended. Last week, HHS published a final rule on the benefits that created a separate out-of-pocket limit for standalone dental plans, but only specifies that the limit be reasonable. There are two huge problems with this approach. First, an additional out-of-pocket limit will make the benefit far less affordable to many families. It was not what Congress intended. The whole point of adding pediatric dental benefits to the essential health benefit package was to make certain that oral health not be considered separate from overall health. We've been here before. This approach is similar to policies that were set decades ago for mental health services. Separate policies to cover mental health treatment, separate limits on coverage, and separate co-pays. Mental health was treated as second-class health care. We know now that this was an injustice. It was wrong to treat those services and patients who use them as second class. Many of my colleagues were here in Congress when we fought the battles for mental health parity. It was a difficult battle, but we won it. It seems to me that this is what we are now doing with dental care. Rather than treating it as a part of the essential benefit package, which was our intent under the Affordable Care Act. Section 1402B of the law also establishes an out-of-pocket limit for all families and lowers that limit for families with incomes under 400% of the federal poverty level. By creating a separate limit, HHS is reducing the number of families who will be able to afford dental care for their children. Second, the rule has left the determination of what is reasonable out-of-pocket limit to each state. With pressure from insurance companies, a state could decide to provide an out-of-pocket limit of $1,000 or more per child, which could more than double the out-of-pocket costs for families with 5 children. In the federally run exchanges, HHS has the authority to set reasonable out-of-pocket limits. Last Thursday, in a Finance Committee hearing, I asked John Bloom, the CMS Deputy Administrator, about the idea of segregating dental benefits from health benefits and increased cost sharing. This is what he said, and I quote, "Well, I think one of the lessons that we learned with the Medicare program is that when the care is siloed, our benefits aren't fully integrated. That often leads to worse dental health care consequences. I can pledge to get back to you with direct answers to your questions, but I do agree with your general principle that when benefit design is broken up and care is not coordinated, that it can often lead to bad quality of care." Well, I agree completely with Mr. Blum. Later that day, I spoke to CMS Acting Administrator Marilyn Travener. I asked her to take into account the affordability of a plan that had a separate high-cost sharing, and she agreed to consider my views. Less than 24 hours later, CMS released a proposed guideline to insurers setting a maximum out-of-pocket limit of $1,000. When I contacted HHS to ask whether this was a per-family or per-child limit, the expert in charge of the rule was unable to tell me. They didn't know whether this meant an extra cost of $1,000 or $5,000 for a family with 5 children. This tells me that the affordability of care was a secondary consideration when the final rule was written. Madam President, there are still millions of American children without coverage for dental care. If we are to make real progress in improving the health of Americans, we cannot afford to continue giving oral health care second-class treatment. The question is now whether the guidance to plans will go forward, how that will be interpreted, and how that will be structured. It's contrary to congressional intent and contrary to the best interests of Americans to allow the proposed rule to stand. On the 6th anniversary of the death of DeMonte Driver, let us pledge to do better for our children.